introduce Megan from Nationwide. So you're going to come up and present. So thank you very much. All right. Yeah.
All right, now that we've all eaten and given blood and are ready for a nap, let's talk about our natural history study, and not only our natural history study, but what that means for clinical trial readiness. So I'm Megan. I'm part of the research physical therapy team. Our fearless leader, Lindsay Alfano, is not available to be here today, so you're stuck with me. But for starters, yay! That's the spirit. So for starters, I want to start by saying thank you. Thank you to everybody. Thank you for being here at the conference. Thank you for everyone who has agreed to participate in our study. Thank you to Cure VCP. And this may be premature, but thank you for everybody who listens to this presentation and then wants to participate in our study.
Megan, can you take the microphone into your hand?
Oh, yeah. Okay. Yes, sorry. So we've talked a lot about natural history studies, and I think we understand what that means. So natural history is documenting the progression and or just the characteristics of a specific diagnosis. So taking that a little bit further, clinical trial readiness, what those types of studies do is they look not only at the performance of the patient, but also the performance of the outcome measures that we use to measure the patient. So it's what we look at, we call the psychometric properties, or the ability of these measures to accurately and meaningfully capture function, motor abilities, things like that, and the ability for them to quantify change over time. So we could just make everybody do the 6-minute walk test, come in every 6 months and do the 6-minute walk test. We could do that, but when it comes time for clinical trial design, when a drug becomes available, and we don't know that that 6-minute walk test is actually good at measuring function and at measuring change over time, then that really doesn't do very much for us. So with that being said, one size does not fit all. Something that works really well in one population does not necessarily work really well in others. So that's why we do these clinical trial readiness studies. So how do we pick our outcomes? There are a bunch of different considerations. There's patient considerations, study-specific considerations, and outcome measures considerations. So from the patient perspective, I don't know if you know this, but trying to get really good standardized functional testing in an adult looks a lot different than it does when trying to get that kind of information from a child. So the way that we design and the measures that we choose, we have to make sure that it is specific to the patient population that we are working with. We also want to make sure that they are clinically meaningful. If you are able to walk 6 minutes or do the 100-meter in a certain amount of time, like, we want to make sure that that is also something that relates to meaning to you within your day-to-day life. And then also variability in performance, especially with when symptom presentation is so different. We want to make sure that we have measures that can measure all of the different types of abilities across the whole group. For our study considerations with the treatment option, we want to know is it a targeted, is it, with IBM there was a intramuscular, are we targeting one muscle for a treatment, or are we looking globally at the whole picture? Are we expecting a complete reversal of disease process? Are we expecting some improvement, or are we expecting slow decline? Those are slower of decline. Those things are really important considerations when choosing outcome measures, and also the duration of the study. And then as far as like the outcomes that we choose, why do we choose those? We want to make sure that if we use a continuous versus an ordinal scale, meaning time is a continuous measure, there's variable intervals. Ordinal scales are much different, where you would usually get like a 0, a 1, or a 2 for an item. Those are sometimes much more difficult to quantify change. but sometimes that they are necessary, and sometimes they really help kind of give a good overall picture of function. We want to limit ceiling and floor effects. That means we want to make sure that not everybody is scoring 100% on the test all the time, and not everybody is scoring 0 on the test all the time, because those types of measures are in the top 10% and the bottom 10 percentile are not going to be good for, are likely not going to be good at measuring change over time. We want to look at the effective motivation and the variability in administration as well. So a little bit about our collaboration. So nobody is going to be able to do this by themselves. It needs to be a collaboration. It needs to be a joint effort. So for Nationwide Children's, we are experts in clinical outcome measures. We have the ability, we have the infrastructure at our site and the flexibility to work with you to make sure that we can, work around your schedules. And we are trained and reliable in the instruments that we use. For Cure VCP, we have a great collaboration with them. They did a lot of advertisement, help with patient preparation, funding, and help getting the kits together for our remote portion of our assessment. And then arguably most importantly, I would say, is the patients that participate. So while we may be experts in outcome measures and clinical trials and things like that, you guys are the experts in yourselves. Like, you know how you function day to day and what that means to you. So you are the most important part, I would say. All right, so what is our study? So our study design is we have 4 baseline visits. So we have a day 1 and day 2 in-person visit. We have a day 1 and day 2 remote visit, and those are scheduled within 1 month of each other. And then we have a 6-month check-in of a remote visit, and then we have at the end of the 1 year, we have a 1-day remote visit and a 1-day baseline, or a 1-day on-site visit. I'll talk a little bit about why we chose that study design, what we're trying to figure out from those things in a little bit. But this was the study design that was taken to the FDA. They thought it looked great. They loved it. The only thing that they had was they said, we would like you to use the Global Impression of Change scale. So we did. So we put it in there. And now we're good to go. All right, so what are we looking at? The assessments that we've included are, we have a physical exam, and that includes just a general exam. That includes sensory testing and strength testing. We have a number of walking tests and motor function tests. So those are timed functional tests or timed walking assessments. We use the North Star assessment for limb-girdle type muscular dystrophies, which is kind of like a gross motor test of abilities. It looks like bed mobility. It looks at getting up from a chair, walking around, things like that. We also looked at hand and arm function and grip strength. We're looking at breathing tests, so we capture forced vital capacity, the forced expiratory volume in the first second. We're looking at maximum expiratory pressure, so the amount, the strength that you have in your breathing out and the strength that you have breathing in. We also have a very extensive series of surveys that we have you take as well after each visit. And then optionally, we have these additional options to opt into if you're interested. We have some neurocognitive testing. We have a biospecimen collection, so we're collecting urine and blood, and that would be used for future biomarker research. And then we have a kind of a retrospective or chart review on bone health. So this is if you've ever had a DEXA, if you haven't had a DEXA, if you've had one that came back without any issues or concerns, all of that information is good information to have. So we have those optionals. So where are we now? So we have 25 people that we have enrolled in our full study. So that is the full 2-day baseline visit, 2-day remote visit, and then back in a year and the 6-month visit. All of those have been completed. By month 12, we have 15 or 60% of our people have completed the full study, and which is not quite where we want to be, but we're getting there. And then we have at least 3 of them have completed part of the 1-year study time point. Additionally, So all of this spans over 17 states in the United States. And actually, just kidding, because work never stops, we have enrolled another person today. So 26. And then we have an additional remote-only visit, a remote-only study. This is for families that it's really infeasible to be able to travel all the way to Nationwide, taking time off work, things like that. So we do have the option to capture some data remotely. And we have 7 enrolled in that, and 2 have gotten up to their 6-month visit. All right, so a little piece of the natural history portion of what we've learned. We'll go into a little bit about our information that we've gathered. And this speaks a little bit to what was spoken to earlier about peripheral neuropathies. So one of the things that we do in the beginning of our first study visit is that we ask patients what they have been given, what diagnosis they've been given by physicians. And so we have 13% of our cohort reported be given a diagnosis of peripheral neuropathy. However, on physical exam, we found that 63% of our cohort, of our group of people, had some reduced sensation or peripheral neuropathy in their lower extremities and 21% in their upper extremities, which is a very big difference from what is being told to you as patients. We also asked about bowel and bladder control, and we had 67% of our group say that yes, they have some issues with bowel or bladder control. And again, this is different than what is, this contrasts what has been reported previously, that 23% of individuals report having some sort of issues in this area. So this information is not to make you anxious. This is not to make you, concerned. What this is supposed to do is provide us more information as clinicians to help guide clinical care. And also, if you are having some of these symptoms, these are what you're experiencing, that you're not alone, and that there's other people around you that are going through this, and it can even give you a voice to then go to your doctor and say, I really do think that this is something that I have. I want you to look further into it. All right, so why 2-day visits? Baseline visits seem like a lot. 4 seems like a lot to do in 1 month. And this is because human performance is variable. So we want the assessments that we do to be we want the assessments that we do to be sensitive to change, to real world, to change that is actually clinically meaningful. We do not want them to be sensitive to variability from day to day. Anything can change how you perform. It could be you didn't sleep very well the night before, you're full and just gave blood, you are fighting with your children and that makes you angry and you don't really want to do anything. So we want measures that are not going to be sensitive to that type of change, but to be sensitive to actual real world, or really clinically meaningful changes. So what this is, you can ignore a bunch of those numbers, but here are a list of some of our assessments that we do. And so as a group, as a whole, between baseline day 1 and baseline day 2, it looks like the group does very well. These assessments perform and they're very stable. So these ICCs are, if 1.0 means that it's the exact match, you did the exact same time or the exact same score on day 1 and day 2. So getting all the way up at like 98%, 96%, that's excellent. So as a group, awesome. However, when we look individually, we can see what these little dots are the difference in performance between day 1 and day 2 of each individual person. So you can see some are less variable than others, but what this tells us is that in order for us to get maximum performance, which is really what we're looking for best performance. For us to actually get best performance, we might need to do 2-day visits at crucial time points in a clinical trial. And especially because if you see not everybody performs worse on day 2 and not everybody performs better on day 2. It's kind of all over the place. So so that being said, that's what that kind of information gives us. And then now looking a little bit more at our functional assessments that we chose and how they perform at one time point. So the NSAD, like I said, is a gross motor assessment. The PUL, or performance of upper limb, or PUL, is an upper extremity and arm and hand assessment. And as we know, the people that we have seen, and as you look around, everybody's function is different. And we can see here that this assessment does a good job at picking up differences in function on very different levels. So the NSAD does a good job, and PUL a little bit not as great of a job, but we want to see that the smattering of dots is kind of equal to the differences in performance that you look and see with each other. And then also, we want to see that there's a strong relationship with the other assessments that we're choosing. So if we are choosing two assessments that are measuring kind of the same construct or the same idea, so motor ability, we have the NSAD and the 100 meter, that's going around a track 2 times as quickly as you can safely. We want to see that the better that you do on this assessment, the better that you do on that assessment. So we want to make, it kind of gives some internal validity to our assessments and some construct validity, saying that this is measuring the same thing as this is, which it is. So that looks pretty good too. For our other timed tests, we time how long it takes to get up from the ground, how long it takes to go up 4 steps, and then how long it takes to get up from the chair, go 3 meters, turn around, and come sit back down. So as you can see, the tug has a nice smattering of abilities also, and of performance. However, if you look time to rise and 4 stair climb, we have a bit of what we'd call a ceiling effect. So that means that everybody who can do it does it very quickly. When we're talking about, if we're looking at a drug that may improve function, if you can do something in 4 seconds, how much room do you have for improvement then? So we want to choose a task that is people are able to do, but also that it is difficult enough that you have room for some improvement, if that is the, yes, sir?
So in the tug, how do you account for patients who are not able to get up from the chair?
We have 25% of our cohort. So that's the thing is, and 50% of our cohort are unable to get up from the ground. So that is also a consideration where it needs to be able to be an item that is able to be done by everybody.
And then do you score them 0? Do you score them?
We leave them off of the graph. Yeah. So for our long list of surveys and patient-reported outcomes, the FDA really wants to make sure that when we provide them information and data, that it relates back to your experience and how you do things. So or how you feel about your life. So unfortunately, there is no VCP disease-specific patient-reported outcome measure. And because of this, we chose a series of outcome measures that have been either validated or are commonly used in the different types of different phenotypes. And what we're looking for here is we want to know, does it measure what it claims to measure? So what we do is look at the relationship between similar functional outcome measures like the PUL and the NSAD, and then how you feel about your abilities with your arms and with your general mobility. And so, like we see, there's a good correlation, a moderate correlation between your report of the upper hand and arm abilities and what we are picking up on our functional measures that we're using. And then also there's a much stronger relationship between the mobility, how you feel like your gross motor abilities, how much difficulty you have doing things, and what we are measuring on our outcome measures. And then we also want to know if what we're measuring is the PRO that we're using, is it able to measure across the spectrum of abilities? So like you see here, like that's a nice, good kind of variation of scores. However, from the natural history standpoint, These three are nice because they tell us that there are people who are experiencing difficulties with community participation, with eating and swallowing and speech. So that's good things to know. However, the fact that a majority of the people are either getting 100% or 0 scores on it tells us that that may not be a really good measure to use in a clinical trial. With the goal here is because one of the fun math things that we can do is we can do what we call a rationalysis. So we can take all of these, and this is kind of the plan, is to take these measures and then kind of look at what items are redundant, what items are more sensitive to change, and we can kind of create our own VCP disease-specific patient-reported outcome measure. All right, and then we have remote testing. So we included the remote stuff for many reasons. One, being part of a clinical trial, being part of any clinical research study is burdensome. It takes a lot to travel. It takes a lot out of you emotionally, physically. So we wanted to try, our whole goal as a research team at Nationwide is to try to reduce the burden of clinical trials. So we wanted to see if, and especially with COVID, we wanted to see if remote testing is possible. And it's feasible. And we found out that yes, it is feasible. So we have great reliability for the assessments done in the clinic. We have a good reliability between the performance in the clinic and the performance at home. However, there are some cons, and some of those are not all of our outcome assessments that we gather in the clinic are feasible to do at home. There's no helper. That's not always a helper is readily available. And for some of our assessments, we do need somebody else to help administer the assessment and or help say go time the assessment. And there is a little bit more variability. For an example, we'll look at that tug that's getting up from a chair, going 3 meters, coming and sitting back down. This is the day 1, day 2 performance, change in performance over 1 day, pretty strong, so 96%, mostly the exact same. And then when we look at on-site and remote, so this is a comparison of the on-site visit versus the remote visit, and this is within 1 month, so we wouldn't expect to see a functional change then. That measure kind of lowers our reliability for the item. So that could be because you're in the home, there's not standardized equipment, there could be distractions, things like that. So those are things to consider as well. And then interestingly, we looked at our global impression of change scale. So that asks you on baseline day 2, regardless of if it was done at home or in person, we asked you if you feel as if you are staying stable, if you're minimally improved, if you are minimally worse, much worse, very worse. So what we found, and although this is definitely not conclusive, but it's interesting to think about, is that the people who did their baseline visits in the people who reported feeling minimally improved did their baseline visits in the clinic. People who reported feeling minimally worse did their baseline visits remotely. And that could be because in a clinical setting, you have a trained evaluator with you. You have someone to kind of help guide you, push you a little bit, also guard you. And it could lead and push you to do something that you wouldn't necessarily feel comfortable doing in your home. Again, not conclusive, but I still think it's interesting and a good consideration for testing in the clinic. So 1-year study results. We wish we would have more, but because we only have 60% of our group having completed the full study, wouldn't be appropriate for me to present any results. I will say that preliminarily, we found that some of our measures are sensitive to change, and that's based on what you've reported and based on what we can measure in the clinic. Our continued analysis, we are looking at and giving insight to how much change happens over a year, and then also what is considered a meaningful change. So stay tuned. So summary, great collaboration. We really appreciate everybody. We found some that are really good at some outcome assessments that are really good at measuring function, some that are not so great within the VCP population. We have great test reliability. Our data suggests or supports 2-day baseline visits, and we are still analyzing. So if you want to participate, I believe our target is hitting 40 for enrollment right now. So if you are interested in participating, please talk to Allison or Nathan or myself, and we would love to get you enrolled and working with us. Thank you. There's our team.